Welcome to the 2013 Sedation Peer-to-Peer Podcast. This educational activity is sponsored by the France Foundation and is supported by an educational grant from Hospira. Today's discussion is presented by Dr. Girard and Dr. Balas. Let's listen in.
We were just talking about, once the patient's CAM-ICU positive, what are the next steps? What we try to do is first identify why they're delirious. So what is causing their delirium? And I said, in most cases, it's either a sign of something changing in terms of their physiologic status, an electrolyte abnormality or a new infection, hypoxemia, things like that, or we evaluate what medications there are. And our pharmacists are actually wonderful and have really taken a leadership role in this regard, particularly on rounds. Once the patient's identified as being delirious, the first thing they're looking at is their medication record to look at those medications that are often associated with delirium.
I think that is a great approach. It's unfortunately, it's common to feel somewhat helpless in terms of what can I do once I've found that a patient is delirious, whether using the CAM-ICU or the delirium screening checklist, both of which are recommended in the guidelines as tools to assess patients who are in the intensive care unit for delirium. I think that it's really common to say, okay, now I have a patient who I've found to be delirious. What do I do about it? And I think that the frustration comes from at least a couple of things. One is that we don't have a tremendous amount of evidence from the standpoint of large multi-center randomized controlled trials saying, here's the magic bullet that you can use to treat delirium in the ICU. This is the drug that has been proven in these trials to eliminate delirium. So if you just assess the patient, identify it, and then give them this medication, all will be well. We don't have that yet. Ideally, some point in the future, we'll have positive trials to guide us in that way, but we're not there yet. And then the other thing that it's frustrating is that often there are multiple potential risk factors or causes that are contributing to a patient's delirium in the ICU. They may be receiving, as you said, medications that are known to be risk factors for critically ill patients. They may also have an infection, which is a very common reason for being in the ICU, infection leading to severe sepsis and organ failure. And we know that sepsis, infection, and organ failure, especially kidney and hepatic failure, lung failure leading to hypoxia, all of these are known risk factors for delirium. So it's tempting to sort of just throw your hands up in the air and say, well, who knows what we should do for this patient. But just because we don't have a randomized controlled trial to tell us there's a single drug that's the best to give for these patients doesn't mean there aren't things that we can do. In the same way that there's never been a randomized controlled trial showing that you need to use source control to manage a patient with an infection, with sepsis. And of course we wouldn't do a randomized controlled trial because no one would ever think it would be ethically appropriate to randomize patients to not having the risk factor for their sepsis managed. In the same way, it would be a tremendous oversight not to look for risk factors for delirium in a patient who's newly found to be delirious in the ICU, and then to respond when you see those risk factors.
You bring up a great point. Whenever I'm doing my teaching regarding delirium, I always emphasize the treatment of delirium is not a medication. The treatment of delirium is to remove the underlying cause of delirium. I mean, that's the treatment. So you remove those risks, if you can, you remove the things that are going to put them at higher risk or might be causing the delirium to extend, and you do the things that you said. Sometimes I tell my nursing students, actually, when older adults in particular come to the ER, they're usually coming with the first symptom being a change in mental status. So it's not always necessarily, I try to say, it's not always necessarily a bad thing. If you're recognizing that they're having a change in mental status, that's your first clue that, something's wrong. We have to figure out what that is. And that recognition of the delirium is so important, and that's why the use of the screening tools that are recommended by the new PAD guidelines is essential. Because without using those tools, we're not really great at recognizing delirium, particularly the hypoactive delirium, which we know is a big problem in the ICU. So I try to tell my students, yes, it's bad that they have delirium. Yes, we have to do everything possible. But in a way, it sometimes alerts us to things that we should be thinking about. Urinary tract infections from the use of Foley's and things like that.
Yes, I agree completely. And going back to your point about medications, I think you're right. Delirium doesn't always or often should not result in a treatment with a medication. In fact, my standard approach with a delirious patient is to try to reduce the number of medications I'm giving them, and if at all possible, eliminate any medications that they're getting that have been associated with the increased risk of delirium. So when I have a delirious patient, instead of adding psychoactive medications, even antipsychotics, which in the past had been widely recommended for the treatment of delirium in the ICU, I tend to actually try to stop all those medications. And anything that could be affecting their brain, I try to stop those medications if at all possible and get everything out of their system and then treat the critical illness as best we can and see where that takes the patient. And my anecdotal experience is that often when you give the patient time to get those medications out of their system, and in the meantime, of course, their critical illness ideally is getting better as well, that you end up in a much better place and that their delirium can improve or resolve.
Yeah, I would agree. I mean, that's been a principle of geriatric medicine for years. The polypharmacy and the effects that it has in removing, medications that are particularly hazardous in older adults. That just hasn't seemed to diffuse to the critical care units as much as it probably should have. And again, it comes back to doing a randomized control trial for basic nursing care. I mean, really, some of the things that have shown to be effective outside the ICU. I mean, it would be really hard to do a kind of randomized control trial of those non-pharm methods because a lot of them are very basic nursing care that really are considered standard of care. So what are you going to do? Randomize people to, not have their, lights on, shades open during the day, and try to promote, to try to normalize at least sleep-wake cycles, and really the emphasis should be on early mobilization, because in the ICU, early mobilization has really been the one thing that's been shown in terms of non-pharmacologic interventions to really reduce not only the incidence but the duration of delirium. So really focus on. I always tell my students, get those patients up, walking, and exhausted, and then they'll sleep better at night.
Yes, and I'm glad you brought up early mobilization, and you used the word. I think you said, try to normalize things, and I think that's a really great way of looking at it. What we want for these patients and what they want for themselves is to return to their normal everyday life, and in the past, it may have seemed sort of unrealistic to think that some of the things that are part of normal everyday life, like being awake and alert and communicative and getting up out of bed and moving around, were things that it was thought to be unrealistic or even inappropriate for those things to be part of the critical care experience. But now we're seeing that not only is it not unrealistic, that it really can happen, but it's tremendously beneficial. So that's definitely another thing that I try to do. And when, getting back to what I said about trying to stop all psychoactive medications or any medications that may be affecting the brain, doing that takes some patience because, it's not a quick fix. It takes some time for the drugs to get out of their system. And one thing that I found is really helpful in the interim, as you wait for those changes to occur and for the drugs to get out of the system, is to get the patient up and moving around. I'm sure that they feel very antsy, and I would have to think it's a common reason for agitation that you're just stuck lying in bed, not able to move around. And patients, when they're up moving around, and for some patients that might mean ambulation, but I certainly don't want to leave anyone with the impression of thinking, look, if you're not having your patient do laps around the ICU, that you haven't been successful in mobilization. It could be much smaller steps, from being able to sit up at the side, on the side of the bed, and dangle the feet and use improve the muscles of posture and balance, and to making some transfers into the chair and so forth. I think that those things can really help the patient, alleviate some of that nervous energy that could develop just from lying in bed, waiting for something to happen, and they feel a lot better.
And even the cognitive stimulation, before that used to be relatively taboo, right? We wanted everything quiet. We didn't want our patients stimulated. We kept patients' family members away from them and things like that. But now even the importance of cognitive stimulation while they're in the ICU, the importance of giving them the ability to communicate, even if they are nonvocal, even if they have the ET tube in, making sure they have a way to communicate. So whether it be writing it down or the use of, those talking valves, or some way that they can feel like they're a human being again, that they have some way of telling us if they're having pain, or that my toe's itchy, or that my nose is itchy. And, when they go to scratch their nose, not reflexively tying them back down to the bed, because of the hazards of immobility and all the consequences that it has. I always challenge people to say, I can give you 20 bad things that occur from keeping your patient in bed. Give me 5. Now, there's always, appropriate responses, increased intracranial pressure, severe hypotension. I mean, that's, in general, the exception rather than the rule. I mean, early in their course of therapy or early in their course of illness, they are very real issues. There are times people need sedation. There are times people may need to be immobilized. But that, in general, if we really reflect on our practice, isn't the majority of their intensive care unit stay. The majority of their intensive care unit stay should be aimed at recovery and fostering recovery.
Yeah, I agree. I wanted to go back to the issue of antipsychotics. So what, like you said, and I agree, there's the treatment for delirium, at least as far as from everything we know right now, is not a medication. So does that mean you don't use antipsychotics at all? Or are there certain instances when you do use an antipsychotic, and then what are those instances if that is the case?
Well, that's funny you bring that up, Tim, right? I have pretty strong feelings, again, not based on a randomized control trial, but a lot of experiences that I've had as a nurse in the intensive care unit. Clearly, nobody's unrealistic. There are clearly people that need to have some of their behaviors controlled when they're experiencing delirium or when they're experiencing another psychosis. So is there a role of antipsychotics in the ICU? Absolutely, yes. Some of the issues that I have with the administration of antipsychotics, particularly in the ICU, is, the side effects that a lot of them have, right? For example, the prolonged QT, and that you shouldn't be using them with patients that have prolonged QT. It's a very rare patient. I would challenge providers to show me a patient in the intensive care unit that doesn't have a medication that's also associated with prolonged QT intervals, or for or things like that are contraindicated for administration of antipsychotics. So absolutely, there's a role. My problem with it kind of comes back to why are we giving the medications? If we're giving so much medication that the patient's not moving, again, we're not treating the delirium, in my opinion. So we're not actively searching anymore. So, okay, the patient's good. They're laying in bed. They're not kicking. They're not screaming. They're not punching. Have we addressed the issue that's causing the delirium, their new UTI? So that's kind of my issue with delirium. Now, so obviously at the Nebraska Medical Center, we work at we're working on an actual antipsychotic protocol right now that has dosage recommendations, whether or not the patients need to be on telemetry or have their EKGs monitored and things like that. So there's clearly a role. Just I personally feel as though they have that risk-benefit ratio has to be considered constantly.
Yeah, I agree, and it sounds like the approach that we take is pretty similar in terms of when would we give an antipsychotic. At this point, I don't treat delirium with antipsychotics. I just don't think that there is strong evidence for my patient population that the drugs work. I would say that I occasionally will use, in a sort of trial and error approach, an antipsychotic for the treatment of agitation. But I don't really have any expectations necessarily that the drug will eliminate the delirium. I'm looking to see if it will help to calm the patient, mostly because I don't want to have to give them some other medication. And I've seen patients who, at least from an anecdotal standpoint, seem to respond to getting an antipsychotic, and therefore their agitation was improved, and they didn't have to get other medications that primarily work by sedating the patient.
That may be more hazardous in some circumstances.
Right, that may be more hazardous, may have other side effects like over-sedation or prolongation of time on the ventilator or so forth, or even making the delirium worse. That's one thing that I try at all costs to avoid, is this sort of vicious cycle of a patient's delirious, they become agitated, and then they get a medication. I think the benzodiazepines are a perfect example that does calm their agitation temporarily, and the reason it calms it is because it just makes them sedated. But then it actually, the effect that it's having on the delirium is, from all the data we have, very likely increasing the risk of prolonging the delirium. And so then once the sedating effects of the benzodiazepine wake off, they return to having an awake, delirious patient who's intermittently agitated, and so then they get more benzos, and they're just in a vicious cycle.
Yeah, it is.
So I think that there's a potential role for antipsychotics in breaking a vicious cycle like that, if you can get away with treating agitation with an antipsychotic. But I pretty much never give antipsychotics for hypoactive delirium. And even when I give those drugs for the hyperactive delirium or the agitated delirium, I don't follow the sort of older approach of escalating doses that are based on what I think is a false assumption that the reason that you haven't seen a response to the drug is because you haven't given a high enough dose.
Do you remember the doses of antipsychotics we used to give in the ICU? I mean,
it was just crazy.
Speaking of the escalating doses, I mean, when I think of what we used to do, thinking that we were nobody wants to hurt their patient. Nobody's suggesting that people have the intention of hurting their patient or doing it to make their job easier. But the doses that we used to use in the ICU, when I would tell geriatricians or when I would tell psychiatrists, they would be like, "Are you kidding me?" And it was just, that's just the way we did it. And again, that wasn't really based on any evidence as much as, some anecdotal reports.
Yes. And so the approach I take, I may give 1 milligram or maybe even up to 5 milligrams of haloperidol, which I think most geriatricians would think was very high dose. But most ICU physicians would say, "Oh, that's a starting dose." But I may give that dose, and I may even over the course of a 24-hour period give several doses. But if I've given 20 milligrams of haloperidol and not seen any sort of benefit in terms of agitation improving or other benefit from the standpoint of the patient's delirium, then I tend to not continue. I tend to not persist in that treatment strategy. And again, I default back to my standard approach, which is to try to get rid of all psychoactive medications as much as possible. And then, of course, like you've said over and over, look for risk factors, look for ways that the critical illness could be contributing to delirium risk, and address those, and then get the patient up and moving around, maintain wakefulness. I think we still have a lot to learn. I fully acknowledge that. But I think these are approaches we can all agree on for now, until we have more information that say, okay, we're going to continue to treat risk factors. We're going to continue to try to avoid medications that are known to increase delirium risk, And now that we've got this new trial showing that this strategy is also helpful, we're going to add that on top. Ideally, that's where we'll be in the future.
I would agree.
This concludes the discussion. We would like to thank Dr. Girard and Dr. Balas for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.sedation-cme.org.